Welcome to this episode of the OT Dude NBCOT Exam Prep Review. I'm Jeff, the OT Dude, and this video will review stroke for the NBCOT exam. As stroke is a big topic, I will try to cover as much as I can in this video, but I highly encourage you to enroll in the course to see all of the content that I have to offer if you are only just watching this on YouTube. It's free to enroll and the link is in the description. Let's get functional. Stroke is also known as a cerebrovascular accident, CVA. In medical speak, the pathophysiology of a stroke is caused by a lesion in the brain. In other words, something, either a block or a bleed, causes a failure to supply oxygen to parts of the brain cells, leading to their death. There are two types of strokes, ischemic and hemorrhagic. An ischemic stroke occurs when a blood clot basically blocks or narrows an artery in the brain. Ischemic stroke is the most common type of stroke, comprising approximately 80% and hemorrhagic 20%. A transient ischemic attack, keyword ischemic, is a transient type of ischemic stroke with reversible defects. TIA symptoms resolve in less than 24 hours. In ischemic stroke, sources or subtypes include embolic strokes, which results when a blood clot breaks loose from elsewhere in the body, such as cardiac sources or vascular sources. A deep venous thrombosis, or DVT, is a possible source of embolic stroke. A thrombotic subtype of ischemic stroke is caused by abnormalities in the arterial vessel wall from atherosclerosis, arteritis, and dissections. Lacunar syndrome or lacunar stroke occurs when one of the branches in the circle of Willis, middle cerebral artery, or neighboring arteries becomes occluded. Before we go into hemorrhagic stroke, let's review hemorrhagic conversion, or sometimes just referred to as conversion or transformation. Basically, what happens is there is first an ischemic stroke. This results in damage in the circulatory system due to cell death, and they are more kind of leaky. What happens then is when blood flow is restored in the brain, these blood vessels leak and become a hemorrhagic stroke. This can have stroke-like symptoms, lead to disability, and death. So why might this happen? It is often encountered with patients who receive anticoagulant therapy and with those undergoing thrombolytic therapy, such as being administered IV TPA maybe too late. I have a specific video topic that touches on TPA and strokes if you're interested in that. So one distinction then between conversion and hemorrhagic stroke is that with hemorrhagic strokes, they are not precluded by an ischemic stroke, but other causes. A hemorrhagic stroke can also occur from an arteriovenous malformation, or AVM, rupturing from the high blood pressure in the blood vessels due to their weakened state. When brain cells do not get the oxygen they need in the brain, they experience cerebral anoxia. And the prognosis of stroke for the patient depends on where the lesions are, the extent of the injury, and if there's a history of strokes, among other factors. Now let's review the symptoms that can occur due to a stroke. The one that most people think about is contralateral hemiplegia or hemiparesis, where you see motor dysfunction. And this may be complicated by shoulder subluxation. In the upper extremities, hemiparesis and hemiplegia may have comorbidities of edema, sensory loss, proprioceptive loss, discoordination or ataxia, altered muscle tone, and pain, which contributes to contractures and even learned non-use. Hemiparesis can range from mild weakness to complete paralysis on the opposite side of the brain lesion. And while people tend to visualize, say, the extremities being affected, it's also important to remember that the trunk can be as well, which results in, say, impaired postural control. An example of this is pusher syndrome that results in the patient pushing away from the non-hemiparetic side and can lose their postural balance in sitting and standing. Another way to think about it is that basically their sense of midline is disturbed, and patients may even be shifted to one side, like away from midline, when they're sitting up in a chair until you kind of like show a mirror in front of them. And because of this poor postural control, they may have pusher syndrome, but also difficulty with weight shifts, balancing, and stepping, resulting in the risk of falls and injuries. This in turn also affects occupations too, such as ADLs and community mobility. So it's not always just the extremities, but there can be any combination and involvement of the extremities and trunk for the individual who has had a stroke. Of course, the arms and hands can be affected as well, and where a lot of the OT interventions are involved. With communication, due to a stroke in one of the brain's communication centers, there may be aphasia and dysarthria. There's global aphasia, Broca's aphasia for expressive communication, Wernicke's aphasia for receptive communication, and anomic aphasia for the inability to find words with expression. Perceptually, the patient may have inattention and neglect, and this can be in different degrees between the person themselves and the environment. This can be anything from body neglect to spatial neglect. And this may be also associated with homonymous hemianopsia and hemi-inattention. Visually, there may be visual field deficits such as visual field cuts or blind spots. Diplopia may be a thing, also figure ground impairment and visual agnosia of the inability to recognize objects. Cognitively, patients may have difficulty with attention, memory, problem solving, safety awareness, planning, basically any of the executive processing skills because, well, it's a brain injury. Oftentimes, the patients I work with also have poor insight into their deficits and may be overconfident in their abilities. Their cognitive endurance is also affected, resulting in them easily fatiguing cognitively, kind of like how you feel after like finals week after your last exam. Many patients experience pain in the affected extremities and may also have a headache, like a lot of times. Their sleep can also be affected, including duration and getting true restful sleep. Other symptoms of stroke include numbness, confusion, dizziness, seizures, nausea, vomiting, and even behavioral changes. Psychosocially, the most common barrier that I see is adjustment to disability, because if you think about it, 1 minute a patient is fine and the next their entire body is not working the way that it used to. And psychosocially, there's an increased incidence of depression, anxiety, lability, social isolation. Some patients may have emotional incontinence or pseudo-bulbar affect, PBA. Check out my video on PBA if you're interested in this topic. But this can lead to embarrassment and social isolation due to uncontrolled crying or laughter in social situations. Let's briefly review the stroke syndromes. This is just FYI, you probably don't need to know this much into the detail, but just in case. A middle cerebral artery stroke, or MCA, CVA is characterized by contralateral hemiplegia, contralateral hemianopia, contralateral anesthesia, or the loss of tactile sensation, dysphagia, aphasia, apraxia, and agnosia. There is also neurogenic bladder and the inability to void. To remember this, the letters C and A in MCA can remind you about the 3 contralaterals and the 3 A's for aphasia, apraxia, and agnosia. An internal carotid artery stroke, or ICA CVA, is very similar to MCA CVA symptoms. An anterior cerebral artery stroke, or ACA CVA, is characterized by contralateral hemiplegia, bilateral anesthesia, homonymous hemianopsia, apraxia, abnormal reflexes, and incontinence. PCA CVA is a posterior cerebral artery stroke and characterized by intention tremors, cerebellar ataxia. This makes sense as it's a posterior and the cerebellum is posterior. Also nerve palsy and visual problems, including eye paralysis, visual agnosia, cortical blindness, ataxia, and even hallucinations. You can remember this for PCA because you would expect more visual problems as the occipital lobe is for vision and located posteriorly in the brain. The last set of syndromes we will review are vertebral basilar syndromes. This is a broader term which includes locked-in syndrome, Millard-Gubler syndrome, Weber syndrome, Benedict syndrome, and Wallenberg syndrome. Locked-in is pretty self-explanatory. Millard-Gubler and Weber syndromes are characterized by ipsilateral, so same-sided nerve palsy. Benedict syndrome is characterized by ipsilateral nerve palsy as well, but also coordination issues contralaterally, such as ataxia and chorea. To remember Benedict syndrome, the actor Benedict Cumberbatch plays Doctor Strange, and he is a superhero who has the superpower to bind opponents and prevent them from moving around. Wallenberg syndrome is characterized by facial pain and loss of sensation, also nystagmus, dysphagia, and dysphonia. In my real-world experience, I often encounter more MCA, ACA, PCA more often than other ones like the vertebral basilar CVA syndromes that I just mentioned. Now let's talk about medical stroke management so that we are all on the same page as the medical team for stroke. The general principle of acute stroke management is stopping the progression of deficits from the lesion, also reducing cerebral edema, preventing hydrocephalus, preventing DVTs, aspiration, and treating seizures. The patient may undergo surgical procedures such as angioplasty and thrombolysis. With ischemic strokes, the restoration of blood flow is of the highest priority. With hemorrhagic strokes, controlling edema is important, as is also preventing rebleeding, maintaining cerebral perfusion, controlling vasospasm, those kinds of things. Overall, we want to prevent the stroke from recurring too. Stroke is one of those things that affects many body systems and its ability to function both on the small scale as well as holistically for the person. Common complications that may arise due to stroke also include contractures, heterotrophic ossification, HO, spasticity, seizures, deconditioning, falls, and psychosocial complications such as adjustment to disability, lability, anxiety, and depression. There may be UTIs due to a neurogenic bladder. There may be incontinence or the need for urinary catheters, which also may increase the risk of UTIs. There is also a high risk for skin breakdown, dysphagia, aspirations, and DVTs as mentioned. As OTs play a role in education, stroke management for the occupation of health management includes lifestyle changes for modifiable risk factors. These include managing and reducing hypertension, smoking and alcohol cessation, managing cardiac conditions and associated diseases and comorbidities, controlling lipids, managing diabetes, and last, increasing overall physical activity. When a patient has a stroke, they usually enter the healthcare system through the emergency room. They may or may not end up in the ICU where you may see them as an OT, but more likely than not, you will encounter them in acute care. From acute care, they can go off into 3 places for discharge planning: home, acute rehab, or skilled nursing facility. Home would typically mean that they have the least of the deficits, all the way up to skilled nursing where they would probably have the most. ARU is kind of somewhere in the middle where I work. This means that they need to be able to tolerate a combination of 3 hours of therapy, say PT, OT, and speech. Or just PT and OT, say if they don't have any speech issues, or say OT and speech if they don't have any PT needs. But most likely for any of these settings, the main goal for discharge is for the patient to go back home and into their community. Besides education on health management of stroke and risky comorbidities, you can imagine that OTs play a role in the rehabilitation of the symptoms mentioned earlier that affect multiple body systems, function, and psychosocial factors. Occupation-wise, OTs of course address ADLs, but also IADLs, sleep, socialization, work, education, and leisure. And it's easy to be very textbook and go at it from a bottom-up perspective or approach. I have thought like this and used this approach before, but because stroke can affect so many symptoms, your mind will literally be spinning from having so many things to work with the patient. So on the NBCOT exam, the best way I think to look at it is with a top-down approach and to think holistically and to be client-centered for the goals and OT interventions you want to do with the patient. Consider the client's roles, their habits, routines, as well as culture, all that stuff in the OTPF. Questions, though, to consider are what is most important for the patient? What are their barriers from their symptoms? How about strengths, environmental advantages and disadvantages, such as barriers to accessing the bathroom? Equipment needs? How about social support system or lack thereof one? Psychosocial issues? And last, what occupations are affected and how can you go at it from an OT perspective? Before we get into OT interventions, one major contraindication for working with patients post-stroke is not to get patients out of bed and mobilize them when they are not appropriate, say when they are on bed rest. This may be because they may have just had a stroke and say a hemorrhagic one less than 24 hours ago, and they may be receiving TPA less than 24 hours ago. Or they had a severe stroke with a high NIH score, or their vital signs are abnormal, such as BP over 200. They are maybe unstable neurologically. Maybe they have an altered level of consciousness, have an unstable cardiac status, maybe a DVT that you suspect, or they're combative and safe to work with. So it's a balance between early mobilization and safety. Besides this, also watch for acute neurological changes such as sudden confusion, seizures. Also, the abbreviation NPO means nothing by mouth, so no food or fluids. How can you measure the effectiveness of OT for CVA? Well, the outcome measures are pretty easy to remember, I think. I mentioned the importance of a top-down approach, so the Canadian Occupational Performance Measure, COPM, and Activity CARDSART are good ones to use. For ADLs in self-care, as well as general functioning, in acute care, the AMPAC 6 clicks is very popular. In acute rehab, we used to use the FIM Functional Independence Measure, but that has been replaced by the CARE tool for documenting, say, with Medicare. Another is the Modified Barthel Index. Other outcome measures that have the terms neurological and stroke are obvious ones that you may want to use or answer for, say, in the CST section. Other more specific measures include, say, for the upper extremity, like the arm motor ability test and Wolf motor function test. For spasticity, the modified Ashworth scale. Simple screens also can be used for vision and visual perception from deficits, say, for homonymous hemianopsia, visual field cuts, and attention and neglect, such as letter cancellation tests and a clock drawing. Another favorite that OT and speech like to use is the MoCA. Also, your commonly used evaluation methods such as sensory testing, MMT, range of motion, coordination, proprioception, things like that too are very useful. This should not all replace the assessment or observation of actual performance skills such as ADLs, like brushing their teeth or feeding themselves or showering, but also IADLs such as reading, finding your way around the hospital, managing prescriptions for health management, so on. Again, as there is often so many symptoms for stroke, there's really a lot of interventions that you can do. And what's important is that you can't do all of them. And one thing that you may be limited by are time constraints, insurance, or other limitations. I personally prefer to use a remedial approach first before integrating compensatory approaches, if I can. Like, I wouldn't introduce a sock aid on, say, day 1 of rehab, really, and just save it safe for the last moment of the last day if the patient cannot learn to do it themselves without it. And this can help to do things like prevent learned non-use for the affected extremity. Commonly used adaptive equipment include reachers, sock aids, dressing sticks, one-handed things such as for cooking, and built-up handles. The list is kind of endless, but safety would trump, I think, everything else, such as me expecting a patient to be ambulatory with occupations, but if they are unsteady and have a lack of tone, then I would say get a wheelchair for that session. Because you have to think big picture, and other staff may be working with the patient as well. They may not be comfortable with things like transfers. So you want to look at safety from a broader perspective, even outside of your therapy sessions. So safety, and communication with the team, those safety concerns. And also a lot of things you should be thinking about before you even get the patient to mobilize or even to move. The things you should consider are cognition and whether they may progress remedially or if they will need assistive devices such as memory notebooks, apps on their smartphone, that kind of thing. Are they alert? Are they oriented? For example, if we are in the hospital, does the patient think they're at home? If they are barely awake, do they seem too fatigued to participate? Then I would know that they probably won't be able to do too much in our therapy session. Are they impulsive and ready to jump out of bed? How about with following directions? Can they follow multi-step directions or only 2-step or only 1-step or not even that consistently 1-step at all? Can they remember those directions or instructions? Because this would determine the grading of the activity itself for the occupation, but also the cues that you would give the patient, including manual hand-over-hand guidance. It's always, of course, possible to, I think, overly help the patient, like during transfers, by doing it so that they're dependent or using like a mechanical lift or something. But you want to maximize the amount of participation of the patient and empower them at the same time. If the patient gives you 25% for a transfer, then that's 25%. Then maybe the next day it's 30, then maybe 50% by discharge. But that's progress. Because you want to be discharge planning as early as possible, perhaps even the first time you're working with them during evaluation. And I may set some lofty goals sometimes, but I have an idea of how long the patient will likely need for recovery, where they will discharge to, or if they're more appropriate for another setting even, such as skilled nursing facility instead of, say, acute care longer, or even being admitted to the acute rehab unit. Because one thing you gotta think about is if you're changing the environment and the staff they're exposed to and what they're learning in rehab, it kind of adds to their confusion and may even prolong the recovery and put more strain on the resources, may cause patient stress. So finding the right setting and putting them there so that they get the best care and what meets their needs may be best. And it may just even be going home to a familiar environment compared to, say, a hospital where they have the best therapists and the best equipment and the best doctors. But if they're stressed out by, having a roommate in the room or whatever it may be, psychosocially, it may not be the best fit for the patient and their recovery. So you got to think about it from this broader holistic perspective. OT intervention and education often involves transfers in preparation for ADLs. And with transfers, you may be the helper, or they may use an object such as a bed rail or armrest. Personally, I prefer this because I feel like it's really strong. And if they can do this, they can be more independent and not need, say, more complicated movements from the staff to assist. But of course, what's the most safest is an important consideration. More specific types of practice that the patient can do include rolling, side lying, say staying on the affected side, or even opposite, the unaffected side. They can bridge, do bridging, weight bearing, supported sitting, unsupported sitting, sit to stands, and leading up to transfers themselves. Common transfers include squat pivot, stand step, and for more higher level, several steps. And a walker is commonly used in rehab by PT and OT, but you don't really use walkers with CVA because they often have hemiparesis in the arms and can't even grip the walker. In a wheelchair, you want to be sure that they are sized properly, supported properly, including their bottom to prevent skin breakdown, and that they're safe, such as not falling or sliding out of the wheelchair. You also want it to have alarms in case they do have a fall so that they may not injure themselves further. Patients can self-propel using a hemi-pushing technique in the wheelchair. Also, you should support the arms, especially to prevent shoulder subluxation and edema, such as with the padded arm trough that goes on the armrests of the wheelchair. You should never pull on the patient's arms, such as during transfers. Also watch for the arms getting stuck in the wheelchair, such as due to hemi inattention and neglect. Sling use is also kind of controversial and mixed, and there are many types of slings, from standard shoulder slings to the Royland hemi sling to the Givemore. One determining factor for which sling to prescribe depends on the patient's overall ability, such as cognition and ability to don and doff it themselves. Otherwise, I think they'll just leave it aside and waste training time and resources. So, more complicated is not always better when a simple sling may be sufficient if only, say, worn during transfers, but they take it off outside of that. Because you still want to reduce the chances of contractures, such as from, say, internal rotation and those synergistic patterns of stroke. And even at bed level, there are many things that you can do when working with the patient. Say, sitting balance, their posture, self-awareness and awareness of the environment with respect to their body and proprioception, range of motion, strengthening, endurance with something as simple as, say, reaching for your hand with weight shifting. So there's a lot you can do, even in sitting in the edge of bed. In unique to stroke, you can incorporate the motor learning approaches, such as bilateral upper extremity training, PNF, constraint-induced movement therapy, mirror therapy, e-stim, mental imagery, videotaped feedback, or even more higher tech ones, such as virtual reality, BioNest, Sabo, and robot-assisted therapy, if your facility has these resources, of course. But you need not always go high-tech when simple, say, self-range of motion, stretching, reaching, and weight-bearing exercises can be effective with motivated learning for neuroplasticity. The requirement, by the way, for CIMT is known as the 10 by 10 by 10 eligibility criteria, which is 10 degrees of active wrist extension, 10 degrees of active thumb abduction, and 10 degrees active extension of any of the other digits in the affected hand. NDT is not really as evidence-based and supported and widely used as it once was, I think, from what I've seen in the research. But overall, one major concept and approach is neuroplasticity. So repetition with, say, self-range of motion and reaching exercises may be very helpful, and also to improve on balance and for functional activities with occupations that are more meaningful than non-meaningful exercises may be helpful. With self-ranging exercises, patients should avoid lifting the arm into end-range shoulder motions such as flexion, like way above the head, as there's a risk of shoulder impingement due to the complex dual action of the scapula when you go into overhead movements and self-ranging. I was also taught to avoid overhead pulley machines, and they may not be a good idea for certain individuals. But splints may also be helpful, such as being worn at night for the hand for, say, spasticity, function, pain, and edema. Examples of some splints for the upper extremity for stroke include finger spreaders, hand cones, commercially available resting hand splints, thumb loops, and thumb abduction orthotics, and also custom fabricated ones to provide support based on the need at the forearm, the wrists, palm, and digits. General splinting principles include providing necessary surface support, removing splint for functional activities, not overstretching muscles and tendons, and maintaining the web space. Edema can also be controlled with PAMs, manual massage, positioning, active use in activities, pressure gloves, and bandages. But remember to check for circulation and perfusion at the distal extremities. CPM, pumps such as those foot pumps that you see, are also used. Don't forget about pain, such as with preparatory activities, PAMs, or interventions such as therapy taping, like kinesio taping of the shoulder. And not all pain is the same. The pain for strokes is usually primarily neuropathic in nature. While you can prescribe homework exercises for patients for when they're not doing therapy, and it may be a good idea, you should find a balance between that and watching out for cognitive fatigue and educating the patient about rest breaks from over cognitive stimulation and cognitive fatigue, such as like what patients like to do, go on smartphones to relax after therapy, but it's very stimulating. So note that, and also mental health and providing social support in the hospital as well as in the community. But really, what patients most would benefit from, I think, is feeling independent and empowered and regaining their sense of self, ability, and independence, and seeing themselves progress. Unfortunately, not all patients can recover to modified independent level or independent level, and this can be tough for patients and families psychologically. So provide coping strategies, stress management, other interventions that you learn for psychosocial that you think may be beneficial for the patient, and also using your therapeutic use of self for the transition from the healthcare system into the community, whether it's with or without family and caregiver support. Because you want to prevent readmission, either from a stroke reoccurring or something else related, such as a fall or orthopedically in nature or neurological injury, DVTs, or a mental health crisis. So OT plays a role in addressing many areas of occupational performance, also for leisure, driving, work, school, volunteering, spirituality, and so on. And while the bread and butter of OT for stroke is often ADL training, you can often address many specific deficits at the same time, such as hemiparesis, hemianopsia, and vision, sensory loss, and cognition, through these occupations simultaneously by doing an activity analysis of what it may involve when planning interventions. You know the saying, killing two birds with one stone? I like to think of it, instead of killing two, multiple birds with one stone, in order to promote carry-over learning and generalization in the home and community. Otherwise, it would take much longer time if we're only working, say, on one or two things at a time, when instead we could be combining multiple interventions together with occupations. For example, to an outsider, it may look like a patient who had a stroke that is practicing, say, folding laundry and having a conversation with the OT is just doing that. But they may be practicing many skills at once: attention, working memory, problem solving, dynamic standing balance, posture, weight bearing, fine motor skills, strength, coordination, endurance, vision and inattention, communication, socialization, and all the psychosocial components as well. So you see, whereas practicing something in isolation, say only weight bearing and standing at a table, like therapy table, and spasticity and tone, you could be doing so much more with the same amount of time, such as simulated IADLs or even more real world ones that have good application. And the patient's performance and their chance of success can be maximized by how you set up the activity, where things are located in the environment intentionally, by grading the activity so that the patient will be more successful, but not overly easy either, by providing too much assistance with, say, verbal, visual, tactile cues, things like that. And we as humans with our brains have to do many things at once, right? We've gotten pretty good at multitasking, even though we don't like to think of it as truly multitasking, such as when we're driving and controlling the vehicle, we may be having a conversation at the same time, right? So I think one goal is to have patients to try to achieve this, or some degree of this. If you have them, say, over-focused cognitively and overworking to, say, walk for functional mobility or for transfers, with like over-cueing them or being super explicit with like instructions and sequencing, then yeah, they may overlearn and over-practice this, but you want them to be able to not consciously think about these things, because normal people don't consciously think about how they're walking or how they're transferring. Like, we don't go, okay, step one, I do this. We just do it naturally, and we're often doing two things at once. This type of multitasking is also called dual tasking. And you want patients to kind of multitask when they're doing things for situations such as driving, walking their dog and having a conversation and looking at their environment. And you can do things like with therapies, even if it's simple as having them walk and counting backwards at the same time, for example, or having, say, a scavenger hunt around the hospital for things on a list while practicing functional mobility, searching around in the environment, practicing balance, and so on. Some safety precautions for ADLs are worth mentioning too. Your patient may ask you for, say, a sip of water or want to brush their teeth, but remember how we reviewed NPO earlier? So look to see if there are any existing precautions, such as for dysphagia and aspiration risks. Your patient may want to shave, but if they are on blood thinners, then they may either have to opt for an electric shaver or have to wait. So razors are a no-no for patients on blood thinners, such as DVT prophylaxis, because if they were to nick themselves, they would have a pretty bad bleed. You should prevent falls, such as during showers or in the bathroom when they are voiding. Dressing is another activity that can cause falls even, such as with donning and doffing pants, but also when the vision is temporarily blocked for those with poor vestibular systems or proprioception, when, say, donning a shirt over the head and their vision is temporarily occluded by their t-shirt. I've had some near falls in these type of situations several times. Also, take advantage of the environment and have the patient stabilize and balance with things like grab bars or stable surfaces. There may be dressing apraxia, which can be addressed with the task-specific training through dressing. One tricky part of dressing apraxia is spatial orientation that is further complicated by ataxia, dysmetria, tone, decreased sensation, proprioception, and even neglect, especially after transfers. But even during functional activities such as standing from a wheelchair for dressing, remember to lock the brakes for the wheelchair or for the bed or other things on wheels. Never step away from a patient if there is a chance of them falling even for a second, say from the edge of bed, due to issues such as poor sitting balance, midline awareness, spasticity, cognition, alertness, weakness, or even seizures. For seizure precautions, patients often have padding when they are put back to bed on the side that the bed rail need to be up to be protecting them in case they do have an episode. And I know a lot of these precautions are common sense, but just prioritize safety, preventing injury, and fall when working with patients with stroke. For dressing and dressing apraxia, interventions include modifying the cues, phrases, and feedback you provide, also changing the clothing and its complexity in visual components such as colors and labels, and changing the environmental factors may be helpful. And for dressing, you can teach the patient adapted one-handed or two-handed dressing techniques for shirts, bras, undergarments, pants, socks, belts, shoes, you name it. For self-feeding, you can address the position at the table, the types of foods they eat, the utensils, plates, or adaptive devices such as plate guards can be used, or rocker knives. Inattention and neglect are common issues for self-feeding and hygiene. Oral care and hygiene such as washing hands and combing hair or shaving are great times to practice weight bearing, standing balance, gross fine motor skills, coordination, dexterity, sensation, and more. For toileting, adaptive techniques with DME such as commodes, grab bars, commodes over toilets, urinals may be very functional. An example of real-world practice for males is donning or doffing the pants, such as with unzipping and standing to urinate, holding a grab bar, or temporarily standing unassisted. With bathing, shower chairs and stools are great to have for safety and fall prevention, as well as non-slip mats, or things like grab bars, handheld shower sprays, long-handled sponges, washing mitts, and one-handed soap pump dispensers for soap and shampoo. Another ADL is sexual activity after stroke, which may have barriers from symptoms of decreased endurance, strength, coordination, libido, erectile and ejaculatory function, decreased vaginal lubrication, decreased sexual performance physically, such as due to motor or sensory impairments, cognitive deficits, communication, and psychosocially for self-esteem and depression. And some things may be helpful include lubrication, but also modifying the position, timing, and other needs, such as due to neurogenic bladder by preempting the bladder and bowel to prevent anxiety and embarrassment, for example. And yes, you can have sex on a wheelchair, and it is an appropriate sexual position as an alternative to using the bed. You can also use the Plicit model to address sexual function and intimacy for patients after a stroke. IADLs. Another common occupation is meal preparation and cooking, which includes working in the kitchen and reaching in the refrigerator or various places in the kitchen. So you can incorporate energy conservation techniques, work simplification, and environmental modifications to make life easier. Adaptive equipment again could be incorporated, such as easy open can openers. Driving is a common question that I get, and you can often get pretty good idea based on your evaluation even, or daily treatment notes of the patient's ability to drive. However, your role as an OT may include the referral to a driving specialist for further evaluation. Other driving resources include the AOTA, NHTSA, which is the Department of Transportation Agency, the AARP, and the National Center for Senior Transportation. Other common IADLs to address include shopping, financial management, laundry, cleaning, or other home maintenance. The home, like the environment, can be addressed for safety and fall prevention, such as for entryways, stairs, surfaces, clutter, lighting, and so on. Where I work, PTs usually address the car transfers, fall recovery, gait, ambulatory aids such as canes, and orthotics such as AFOs. Commonly used ambulatory devices include single-point canes, quad canes, hemi walkers, the ones that look like step ladders or step stools to me, and more rarely crutches. Orthotics to be familiar with are the AFOs, or the ankle-foot orthosis, and the KFOS, which is knee, ankle, foot orthosis. It's in the abbreviation. When promoting leisure, some things to keep in mind include one's stage of life, their social environment, culture, roles, habits, routines, and the patient's barriers, whether it's physical, cognitive, spiritual, psychosocial. And it may be easy to get caught up in, say, like the ADLs, but leisure is not an area that you should overlook because it provides many benefits from function to stress management to socialization to physical wellness. For visual dysfunction, I won't go into the more specific interventions, but there is eye occlusion and scanning strategies. But some examples of more participation and engaging activities include making a bed, doing laundry, playing board games, sports, or cleaning a room. My favorite is using playing cards with a wide search pattern and search strategy that incorporates transfers and standing balance and standing endurance, as much as I can incorporate in that session. As patients may have aphasia, dysarthria, and other communication barriers after stroke, here are some general guidelines for communication. You should face the patient, speak slowly, allow the patient time, encourage more participation like with talking, write down important things, use alternative means of communication, pay attention to nonverbal language, simplify language and the phrases you use to more common words, say the same thing differently if you need to repeat yourself, use augmentative systems such as written, and to try to anticipate the patient's needs before they need to ask. And of course, collaborate with speech-language pathology. Psychosocially, I often find patients facing barriers of adjustment to disability. Among strokes, prevalent conditions include anxiety, PTSD, and depression. 1 in 3 stroke survivors may have depression. So providing family-centered or patient-centered interventions and addressing social participation and preventing isolation and occupational deprivation is essential to maximizing a stroke survivor's mental health, quality of life, and participation in those meaningful occupations. So I hope this helps. If you found this video helpful, give it a thumbs up and share it with your study groups. I'm Jeff, the OT Dude, and good luck studying.